On this edition of Science News, I'm joined, of course, with Bob Harrington, President of the American Heart Association, and our President-elect, Mitch Elkind. And we're going to review here at ESC 19, here in Paris, some of the groundbreaking trials as well as the implications that it has for our colleagues back home. Bob, I'm going to start with you for you to review Paragon HF.
Yeah, Paragon HF, one of several important heart failure trials that were presented in the hotline sessions here at ESC, went after what I would say is a difficult patient population that we all see in practice, and that is the heart failure patient with preserved ejection fraction. Not a lot of new therapies for this group of patients. A lot of trials where people have sort of struck out in this group of patients, and so we're left with what I'll say is therapies which have mostly been used in the reduced ejection fraction population applied to that group.
Yes.
But as we all know, difficult group patients to manage.
You bet.
So in Paragon HF, they built upon the observation from the reduced ejection fraction population with the angiotensin receptor and niprolysin inhibitor combination therapy that showed so successful in reducing hospitalization and mortality in the reduced ejection fraction population. Could you apply that therapy to the preserved ejection fraction population?
Important question.
Really important question. They did a large clinical trial, very well designed, very well powered, drug versus standard care, on the backdrop of everyone getting good heart failure management. And what did they find? Well, the primary endpoint was the composite, as is often in the heart failure trials, of the combination, the composite of death or heart failure hospitalizations, and they just missed. P-value of 0.06. And so certainly directionally it favored the experimental therapy, but by conventional statistical terms didn't meet it. But there were a couple of interesting observations in the analysis. First off, they showed in their multiple subgroup testing that there were a couple of subgroups where it showed a positive interaction term, and the most interesting one was in women.
Interested.
And so a positive interaction term, meaning there may be some heterogeneity of effect. It looked like it benefited. Now, from a pure clinical trials perspective, all you can say is that's hypothesis generating, that's interesting. But I think it raises a bigger question, Ivor and Mitch. It raises this question of, we call it preserved ejection fraction, but there's no way it's one disease. And Sanjeev Shah from Northwestern has done some beautiful work in this and trying to subclassify using a technique called phenomapping, different phenotypes of patients with preserved ejection fraction. So, trial that just barely misses, but I think a lot of information is going to come out of this. And here's my nickel down. I'll bet that there are some patients with preserved ejection fraction that do benefit. Now the researchers have to tell us which ones those are.
So actually, Bob, you're spot on, because in a session that I co-chaired with our ESC President Barbara Cassidy, we specifically had, for world-class investigators that are talking about the biology, and they're talking about subphenotyping, and I think that you're really on to something. But again, here we have clinical trials that are designed to either address efficacy or effectiveness, and we recognize specifically for heart failure with preserved ejection fraction, which could be almost 50% of that population, where there's still more that we need to learn about the biology that will in turn provide the foundations for effective therapies. More needs to be done in that area.
More needs to be done. So I don't like calling things positive and negative trials. This was an informative trial.
So kudos for the investigators for taking on those challenges and still pointing out more work that needs to be done. Mitch, I'm going to turn to you now to talk a little bit more about what's been happening in the area of salt substitution and treatment for patients.
Sure, thanks, Ivor. Yesterday we heard a little bit about the importance of hypertension management in the low-income countries and in the global setting, and how important hypertension is. The HOPE-4 trial showed the benefits of a comprehensive management strategy for those patients. And now we have another trial that actually demonstrates the benefit of salt substitution to reducing blood pressure, again in the low-income setting. So the investigators in Peru from the Crónica Center in Peru did a really interesting study in which they randomized villages in Peru to receiving standard salt that would be used in cooking, or a salt substitute that contained 25% potassium chloride. You know, there's been evidence that potassium chloride can reduce blood pressure in some settings, but people don't necessarily use it. It might affect how the food tastes, and so people just don't want to cook with it. But the investigators determined what an appropriate ratio would be between sodium chloride and potassium chloride to come up with this substitute, and then using social marketing, we're able to get these villages to use this salt substitute. And they actually found in several thousand people that they were able to reduce blood pressure levels by about 2 millimeters of mercury or so, which may sound like a pretty modest change, but even very small changes in blood pressure across a population can have tremendous benefits. So I'm very excited about this. To me, it sounds like the implementation of that mass approach to prevention, which is so important, and especially in limited resource settings. There were no drugs involved. It was purely changing the composition of the salt people used to cook every day.
So big and important implications. Bob, I've actually heard you talk about the types of trials that NIH should take home when it comes to salt.
Yeah.
Your thoughts?
I too thought this was a terrific trial. They used creative design with a step wedge randomization. So very pragmatic trial.
Yeah.
Randomized the villages as opposed to individuals. And as you rightly said, this is really about a population strategy.
Yes.
What I found intriguing, and we were talking about this offline, is that we're saying limited resources as though that refers to only outside the U.S. These results are applicable perhaps to the U.S., where we have plenty of health disparities, plenty of communities that are not having rich resources pumped in, no access to new drugs, etc. So I like this study for a lot of reasons, including its U.S. applicability.
Yeah, I think that's a great point.
So we're going to talk next, if you will, about popular genetics, if you will.
Populations to genetics,
as we appropriately it should. So tell us a little bit more about this trial that is actually looking at CYP2 genotype and its consequences in terms of management of patients with ischemic heart disease.
Yeah, well, as you both know, this has been an interesting question for a long time now.
Yes.
That clopidogrel, which has been a very effective mainstay drug for all of us in our patients with stroke, with cerebral vascular disease, with heart attacks, with stenting, is limited by the fact that there are a group of patients, actually a substantial group, maybe as much as a third, that have a genetic mutation, the CYP2C19 loss of function allele. That means they don't metabolize it, and because clopidogrel requires metabolism to be an effective drug, they just don't get a benefit. They can't get a benefit from it because they're not getting the active metabolite. And so it was one of the reasons the new generation drugs like ticagrelor or prasugrel were developed. Both of those drugs, as we all know, have been shown to be superior in clinical trials to clopidogrel. But clopidogrel remains the dominant P2Y12 inhibitor used worldwide. Why is that? It's because of cost. And it's now a generic drug. And so are there ways to think about utilizing clopidogrel with knowledge of the genetics that might sort of mitigate some of the advantage of ticagrelor and prasugrel? So they did a very clever study here in several countries in Europe where they have a point-of-care genetic testing device. They took a group of patients with ST segment elevation MI, clearly high thrombotic risk, and randomized them to standard therapy with ticagrelor or prasugrel, or genotyping.
At point of care.
At point of care, directed therapy. And so in the loss of function group, they gave them ticagrelor or prasugrel. In the other 2/3, they gave them clopidogrel. Primary endpoint was looking at non-inferiority, both on the ischemic events and combined with the bleeding events, and bleeding superiorities, suggesting that the clopidogrel would have less bleeding. And in fact, they hit on both regards, that there was less bleeding with the genotype-guided therapy because you're using more clopidogrel. And on the ischemic events, there was non-inferiority. There was not a difference between the two groups. So this has been a topic which just keeps rearing its head every few years. Should we genotype everyone? It really is a cost issue in many ways because the ticagrelor and prasugrel are superior. I think that if it is a cost issue and you think that you would do better off being able to choose clopidogrel for 2/3 of your patient, I think the strategy really points out that this is possible.
So, we talk a lot about precision medicine, i.e. the right cost for the right patient at the right price. And I think that this will particularly be applicable for other types of diseases, if you will, not just restricted to the coronary vessels. That might also have implications for even management at the appropriate time in patients with cerebrovascular disease.
Absolutely. No, I think we've seen the same kind of shift in thinking within the world of stroke. Definitely stroke subtyping, using genetic profiling to determine response to drugs. All of this is very relevant to what stroke neurologists are doing as well.
My only caution is that let's make sure that we study it in an appropriately rigorous way like this group of investigators does, because it seems so obvious that if you can genotype out that group that doesn't respond, but previous clinical trials have not successfully shown that. In particular, if you looked at platelet function assays, they have not particularly shown that. So let's make so this trial clearly has given us maybe a path forward. But I think we want to be careful.
And it points, whatever we're going to do has to happen at point of care.
Yes.
So that we can really be...
So you can react.
So you can react and be able to obviously reduce complications and obviously improve outcomes. Maybe what we can do now, both Bob and Mitch, is let's step back and think more broadly. We've been here at ESC 19, and let's just sort of talk about some of the studies that you think are going to be, I don't want to sort of use this word game changer. We sometimes tend to overuse it. But, just to, kick it off, we heard at these meetings about, these sodium glucose transport inhibitors, which, of course, are appropriate for patients who are diabetics. But one of the studies, this DAPA-HF study, that actually asked the question, now that we actually have evidence-based therapies for heart failure, what about the person who has heart failure but is non-diabetic? And I actually thought it was fascinating that they were able to actually use these SGLT2 inhibitors and actually showed it reduced hospitalizations. You're able actually to improve outcomes. And last but not least, patients actually felt better. I actually think that that's actually going to be having some significant implications. At the biological level, as you know, these SGLT2 inhibitors are actually in the kidney, and not necessarily the heart. So you actually now have agents that are actually having systemic effects. That to me is very exciting, and I think it's going to have implications. Perhaps you want to just reflect about some other studies, just not any in particular that you may want to be able to discuss. Mitch, let me start with you.
Sure. Well, I've been very impressed with some of the global health implications as we've been discussing. And just today, in fact, there's a big report of the changing demographics of cardiovascular disease around the world. And some of the good news is a slight decrement in cardiovascular disease in general in high-income and middle-income countries, which I think we can take as a sign that a lot of the great work that's been highlighted here at the meeting has had over several years. But at the same time, we're seeing an increase in cardiovascular disease in low-income countries for just the reasons we've been talking about. Decreased access to medications, decreased access to care. And I think we've also seen some potential solutions to how to deal with those problems in the use of non-physician providers, in the HOPE-4 trial, as we said, interesting strategies to addressing dietary issues and salt consumption, as we were just talking about. So I think, the good news is that cardiovascular disease is coming down in some parts of the world, but we have to be mindful that the battle isn't over yet.
Absolutely. So, Bob, as you know, we all are going to be preparing in the next day or two to head back stateside. I can't help being excited about Scientific Sessions 2019, for which you were going to be presiding over. Your thoughts?
Well, both of you mentioned some of my highlights of the meeting. Certainly all the information here that was about prevention. I remember in the opening ceremony, the ESC president, Barbara Cassidy, said, knowing is not enough.
Yes.
We must apply what we know.
Absolutely.
And what we really saw at from these trials that you've mentioned, Mitch, is applying what we know. These aren't new drugs.
Yep.
Let's just apply what we know, implementation science. And the SGL2 inhibitor trial, home run. And that potentially is something that will change practice. We want to see the full publication and all of that.
You got it.
But boy, does it look exciting. To looking ahead to sessions, to me, this meeting has also been loaded with digital technology. We're sending you videos from Paris. We're using social media. And you think, well, do I even have to go to meetings? But there is a buzz and an ability to be able to talk to your colleagues in the hallway. You see people discussing and arguing, and people going up to presenters after the presentation and say, hey, tell me a little bit more. And so there is that immediacy of being able to interact with colleagues, ask questions, really, and get a deep immersion. I mean, how many trials have we seen in the last few days? A lot. How many sessions have we been to? A lot. It's really a great way to get a deep dive. So thanks, Ivor, for the sessions plug. We look forward to seeing a lot of our friends and colleagues in Philadelphia for the first time.
Yep. Look, on that note, Ivor Benjamin, and both again for Bob Harrington and Mitch Elkind, thank you so very much for joining us, and we will see you next time.